Mortality following blood transfusion for non-variceal upper gastrointestinal bleeding by Dr. Taha and colleagues, University of Glasgow and Crosshouse Hospital, Kilmarnock, Scotland, United Kingdom. The wisdom and safety of blood transfusion are being questioned in mild and moderate cases of upper gastrointestinal bleeding in light of falling donor numbers and the high morbidity and mortality observed in patients treated in intensive therapeutic units after trauma and after surgery. We therefore aim to measure mortality following blood transfusion for non-variceal bleeding at 30 days and 2 years over a 6-year period. Adult patients were included if they had non-variceal bleeding and regardless of their comorbidity or the cause of their bleeding. They were excluded if they had esophageal or gastric varices, portal hypertensive gastropathy, or if they were endoscoped but were well enough not to require hospital admission. Patients' assessments included the following: hemoglobin and other routine blood tests, endoscopy, comorbidity using Charlson's score, the complete RUCL score for upper gastrointestinal bleeding, the need for blood transfusion, and death of any cause. 1,776 patients presented with upper gastrointestinal bleeding, of whom the following were excluded: 90 with varices, 341 who were not admitted, and 5 who had incomplete data. The remaining 1,340 patients with non-variceal bleeding were analyzed, and 42% of these were transfused. The overall mortality, regardless of transfusion, was 5.3% within 30 days and 25.8% within 2 years. As for demography, patients who were transfused were significantly older and had higher comorbidity scores than those who were not transfused. Also, the transfused patients had higher RUCL scores and lower hemoglobin levels. The overall cumulative mortality was significantly higher in the transfused patients over the 24-month period of observation following upper gastrointestinal bleeding. When patients were subgrouped according to their baseline hemoglobin level, the 30-day mortality was higher in those transfused having had a hemoglobin level greater than 10 grams per deciliter. Similarly, the 2-year mortality was higher in patients transfused when their hemoglobin level was greater than 8 or 10 grams per deciliter. The hazards ratio for 30-day mortality following blood transfusion was still higher even after adjustment for RUCL score, hemoglobin, age, and Charlson comorbidity score. The same applies to the hazards ratio for the 2-year mortality following blood transfusion. In conclusion, mortality is higher following blood transfusion for non-variceal upper gastrointestinal bleeding. Alternatively, the need for transfusion might predict mortality following non-variceal bleeding. The take-home message from our observations is that the need for blood transfusion should be reviewed in less severe cases of non-variceal upper gastrointestinal bleeding. Also, blood transfusion should be avoided or deferred if the hemoglobin level is greater than 8 grams per deciliter, and particularly if the hemoglobin level is greater than 10 grams per deciliter. Thank you for your interest in our work.